Welcome to the Move Better Project's IT band syndrome program. In this first video, we're going to cover three topics. First, we're going to talk about the anatomy of the IT band and why it's different from what many people think. Second, we're going to talk about what causes the pain on the outside of the knee that we associate with IT band syndrome and why it's not friction, as many believe. And third, we're going to talk about the factors that lead to people developing IT band syndrome in the first place. The point of this video is for you to understand the context around that pain that's in your knee, and so you understand the why behind a lot of the mobilization, stretches, and exercises that I'll have you do during the rehab portion of this program. With that said, let's get into it. This strap right here represents what most people think the IT band looks like inside the human body. So it connects to the side of the pelvis on this bone called the ilium right here, and it goes down to just past the knee joint to connect on to the tibia. Iliotibial band, simple enough, right? A couple muscles connect or insert into that connective tissue, the TFL or tensor fascia lata, which is just in front of the hip joint here. Its fibers connect into the IT band, and the gluteus maximus, this major butt muscle just behind the hip joint, has some fibers that connect into it as well. Iliotibial band syndrome used to be called iliotibial band friction syndrome, and the belief was that as you repetitively flexed and extended your knee, you can see that band moving back and forth, that it caused some friction at something called the lateral epicondyle, which is a bony prominence on the side of the femur right here. So the problem with this anatomical description is that while it's all true, it's kind of incomplete. There's a lot more connections than just at the top and bottom and a couple muscles to the IT band. If we actually look at all the different connections that are happening, the IT band has connections to the lateral quad muscle, vastus lateralis. It's got connections to the patellar, the kneecap. It's got a connection to the tendon of rectus femoris, this middle quad muscle. It's got a connection to the lateral epicondyle of the femur right there, and it has connections through its entire length to the femur, kind of between the quads and the hamstrings there. And more important than any of that, this band is not just a strap that exists in isolation, but it's really a thickening of something called the fascia lata, which is this piece of connective tissue that wraps the entire leg, really all the way up from the pelvis, all the way down to the foot. So as you can see, given how connected this thing is, it's not going to slide back and forth. So friction is not the cause of IT band syndrome. This thing is not moving back and forth very much, given how connected it is to almost everything in this lateral thigh and throughout the lower extremity. So given that, what does actually cause the pain on the side of the knee that we associate with IT band syndrome? So while the IT band can't slide back and forth and create friction, it can squeeze inward and create compression. And that is the real problem that we think is happening when people have IT band syndrome, this lateral knee pain. The IT band, if tension on it increases, whether that's we move the two ends further apart or tighten the muscles that attach into it, it's going to move inward this direction. And the femur, as it comes down, kind of moves out in both the lateral and medial directions to form these things called epicondyles. And that lateral epicondyle, which you can feel here, this bony prominence just above the knee joint, there's not much space in between the IT band and the lateral epicondyle. And when that tension increases, it squeezes inward. There's a little piece of connective tissue and fat that's very sensitive in there. If you compress it for long enough, it's going to become painful. So if the problem is that we're getting compression here at the lateral epicondyle because the IT band has too much tension, what would have caused that tension to arise in the first place? Well, we can look at two factors. One is that the muscles that insert into the IT band become tight themselves or get too much tension on them. The muscle with the most connections is tensor fascia lata, TFL, right here in the front of the hip. And that muscle tends to become very tight for a couple reasons. One is that we spend a lot of time sitting. Of course, modern people spend way too much time in chairs. So any muscle on the front of the hip here is going to get used to being in a shortened position. So then when I come to fully standing or doing an activity like running that requires hip extension, that muscle is not going to have the length to be in that position or to be used to being in that position. Second is that muscle, TFL in particular, gets really overworked. It's part of three muscles, TFL, gluteus medius, and gluteus minimus in there deeper, that abduct the hip. So hip abduction is moving the femur out to the side here. That's what we kind of think of the movement of it, but it's also, if my foot is down, it's preventing the other hip from dropping down. So when you go running, every step you land, the hip abductor muscles have to work to prevent the opposite hip from dropping down. So those three muscles, TFL, glute med, and glute min, are supposed to work together nicely and have a balance. They have little different lines of pull, they can operate in different directions, and it's supposed to be this really nice system. The problem is that for a variety of reasons, TFL tends to get overworked and tends to do much more of that hip abduction or sort of hip and knee stabilization work than the other two. The second reason we can develop too much tension on a tissue is we just take the two ends of it and move them farther apart. If you do that, that's going to increase the tension, as you can imagine. The farthest attachments of the IT band are up here on the iliac crest on the side of the pelvis, and down here on a little bony prominence on the tibia on the side of the shin here called Gerdy's tubercle. To move those further apart, we can adduct or bring the femur across the midline like this. You can see that strap goes from loose to tight when I do that, or internally rotate the femur and basically turn that knee inward. And what studies have shown is that runners and other people who have IT band syndrome tend to spend much more time and move into those positions much more of adduction, moving inward, and internal rotation. It should be noted that the movement pattern and the tight muscles are interrelated. If your TFL is tight, that's going to pull your femur into internal rotation. If your hip abductor muscles, your glute med and glute min, are weak, that's going to lead to your knee coming inward and your femur adducting. So these patterns are all linked together. And our rehab program is going to address all of it, the tight muscles, the movement patterns, and begin to feed some slack into that overtension system and teach you how to move in a way to prevent that from getting tight in the first place. The first and most important step then in treating IT band syndrome is going to be to reduce the tension on the IT band itself. We're going to do that by treating the tight muscles that we discussed and correcting the movement patterns that lead to that IT band getting too tight in the first place. The specific exercises are going to be in future videos during the rehab portion, but hopefully this has helped you to understand why that pain in the side of your knee has to deal with a lot of different things that go all the way from the pelvis down to the lower leg.